Hi, I'm Dr. Jack West, medical oncologist from Swedish Cancer Institute in Seattle, Washington, and I'm also the founder and president of GRACE, Global Resource for Advancing Cancer Education. And I'm happy to be here for a post-ASCO 2017 update with two of my colleagues. With me is Dr. Matt Gubens, who is Associate Professor in Medical Oncology, Specialist in Thoracic Oncology at the University of California, San Francisco, and Dr. Jyoti Patel, who is Professor in Medical Oncology at the University of Chicago in Chicago. Thanks for joining us.
Thank you.
Thanks for having us.
We also saw some new data with a third-generation ALK inhibitor called Lorlatinib, and we haven't seen as much about this in presented clinical trial form as some of the other ones, but I think this has generated some interest as a potential answer to where do we go after a patient has progressed on one of the very useful second-generation ALK inhibitors like Alecensa, like Alunbrig or brigatinib as well. So, Matt, what do you think of the data that we were seeing, and how might this fit in now or in the next few years?
As you say, Jack, it really is a crowded field, and so some of the challenge has been how to evaluate these drugs. When we have great drugs to give patients already, when do you choose the other drugs? And so I think one of the interesting things about this particular trial with Lorlatinib was they really looked at people who had one shot at an ALK therapy, 2 shots at an ALK therapy, even 3 and 4 shots at different drugs, and kind of showing us that some number of patients at every step along the way still got a benefit. Now, maybe different by line of therapy. That's really an important point to say maybe we can sequence these and find a way to determine in what order to give them in a given patient rather than have to resort, as we eventually do, to chemotherapy or immunotherapy. One of the insights we're just starting to be on the cusp of learning is why is it that these ALK-driven tumors progress on these drugs? Because as good as alectinib or Alecensa is, we do know that most patients will progress. Maybe it's a longer period of time, that's the promise. But the science now trying to figure out what drives that change. How is the tumor evolved past Alecensa or Xalkori? Any of these drugs is really going to come to the fore. And I think we envision a day in the next few years where maybe these biopsies at the point of progression may drive that decision as we know which drugs respond to which resistance mechanisms.
Any other thoughts, Jyoti?
We have 4 approved drugs, and it's likely that we'll end up with a 5th drug in the next couple of years. And so I absolutely agree that we need to make sure we're investing in some of that foundational science to understand why some patients are more sensitive to one drug than another.
And by that you mean potentially getting repeat biopsies either from a blood test, a plasma send-off, or even a repeat biopsy of tissue.
Exactly.
To try to figure out which patients are more or less likely to benefit?
Exactly, and to sort of develop a blueprint, if you will, of which patient characteristics and tumor type or mutation type may predict sensitivity to particular drugs.
Were you impressed by the Lorlatinib data? Is that if you have a patient who progresses on alectinib, are you going to be inclined to go back to the ALK approach, or knowing that patients can still benefit from chemo, where do you think chemo versus a sequence of ALK inhibitors is going?
So you bring up a great point, Jack. Certainly we know that patients with ALK translocations do quite well on chemotherapy. We know drugs in particular like Alimta have a fair bit of efficacy in control cancer for a long time. It may be, as we learn this, that chemotherapy may be sort of a pathway to control the cancer and then rebooting to another oral drug. Chemotherapy in these patients, again, is pretty well tolerated, and it might be for a finite time. At this juncture, we have Lorlatinib, which we're excited about, but is only available at clinical trial centers, at a few select clinical trial centers. Brigatinib may have a role, Alunbrig after alectinib, but again, we're sorting out that science and numbers have been small.
Yeah, we just don't know. These are drugs that are pretty similar, but we just don't know for sure if they're similar enough that there wouldn't be a benefit to giving one after another. But I think it's important for us to underscore that chemotherapy is not useless consolation prize treatment. That my sense is that a lot of patients who have been on an oral therapy and seen good results tend to see chemo as a really undesired subsequent option, but it's not anathema. It's really something that can help a lot of patients. We just need to figure out the sequence.
And particularly drugs like Lorlatinib, again, we know that these patients have good control with that particular agent, but have patients, as you do, who continue to work and raise their families and do the things that are important to them despite being on infusional chemotherapy.
Okay.
That's a really important insight, I think, that we really think of, especially these targeted mutations, as being a marathon, not a sprint. And patients really can cycle through maybe multiple agents against ALK, spend some time on chemotherapy, come on back to the ALK drugs. And as we learn and get more drugs in our armamentarium, there'll be this opportunity to really live with disease and live well with disease for quite some time.
Right. We do think about the possibility of a break from these directed therapies that you may resensitize with multiple different agents to potentially sequence. It may be helpful to alternate. We'll learn more about this in the coming few years.